thought what I would do today is tell you, I think it's important for you to understand a little bit about who I am, to understand a little bit about pain. So bear with me and take a nap over the next 5 minutes because I'll tell you just a little bit about my life story. But I was working on my undergraduate degree in marketing and finance and had never really heard about pain. Didn't know what pain was. I was very excited. I had my real estate license in college and would go home and work with my mother in real estate in the summertime and what have you. And then my junior year of college, I had a twin sister. And our junior year of college, we were at my grandparents' home. My grandfather was a surgeon. And she kept complaining of pain in her side all day on Easter Sunday. And and my grandfather, the old family prior, the old surgeon would say, "It's just gas, don't worry about it." And so the day progressed throughout the day, and about 4 o'clock Easter Sunday, he said, "Lay down on the sofa." So she laid down on the sofa and he palpated her side, and sure enough, she had a tumor about the size of a grapefruit. And so for the next 4 years, I was with my sister at MD Anderson Cancer Hospital in Houston. And they would do surgery and remove a tumor and do chemotherapy, and she would be fine for about 6 months and think, oh my gosh, I'm going to go back to work and my life is going to be productive and quality of life is coming back, and the tumor would grow back somewhere else. And they would repeat it, and they did that for 5 years. And unfortunately, she died 5 years later. And exactly 1 year later, I had an older sister, my oldest sister, who was a recovering heroin addict. She had been in Betty Ford and Sierra Tucson and several treatment programs around the country. And a year to the day that my sister died from cancer, my oldest sister fell off of an 8-story balcony somehow and fell on the street in Portland, Oregon, and died. And my sister's cancer doctor, her oncologist, was a very famous pain physician who wrote most of the textbooks on oncology and pain. And he actually came to her funeral, which was really rare. And he sat next to me at my sister's funeral and was very kind and gentle. His wife was his nurse, and she was there. And he said, "Come to my office next week." I said, "Why in the world would you want me to come to your office?" And he said, "Just come visit." And so I went to his office the next week, and I sat down with Dr. Hill and his wife, and he looked at me and he said, "Have you ever heard of Al-Anon?" And I said, "I've heard of it." And he said, "You need to go." So he explained what Al-Anon is. I'm not in recovery from drug and alcohol addiction. I'm in recovery really from my family and the experiences I experienced with my family and addiction within my own family. And he said, "I watched you for 5 years with your sister and your mom and your family, and you need to go back to school." And I said, "I'm already working on my MBA." And he said, "No, you need to go back to school and work with people who have pain and addiction." And I thought about it for a little while, and about 3 months later, he said, "Let me take you to the University of Washington. I'm speaking there in a few weeks." And he said, "Come with my wife and I to University of Washington from Houston." And I did, and that kind of wrote my story. I went back to school and entered the University of Washington. And University of Washington is brag on it for just a minute. It's the oldest multidisciplinary pain program in the United States, probably the world. It was founded in 1952 by Dr. Melzack and Dr. Wall, who are two very famous psychiatrists and psychologists in our field of pain. And they were the first two people that said that pain is not just physical. Physical pain is a lot more than a physical complaint. It involves emotions, and it involves anxiety and fear and depression and grief and trauma and sleeplessness and poor nutrition and loss of intimacy. And really, our lives begin to spiral out of control when we don't know what to do with our chronic pain. And so we'll talk just a little bit about it. But before we do that, Josh, if you'll go ahead. So this is Macklemore, of course. I don't know if any of you know who Macklemore is, but Macklemore is in recovery, a very famous musician. And he went to treatment for opiate addiction. And he fell and broke his wrist on stage and had an ongoing pain complaint, very brief, acute pain. And he went to the doctor, and the doctor wrote him a prescription for 360 hydrocodone in one prescription. The very first visit, right? Why not? 360 hydrocodone. That's kind of what we face. And so his life began to spiral out of control with opiates, and ended up, he went to treatment a couple of years later after his life spiraled out of control, and he wrote a song, and it's going to be about 3 minutes of probably grueling words that you're going to hear. But I like to play this song every once in a while to an audience that I haven't spoken with, because this is what opiates and pain are doing in the United States, and what I'm learning over the last couple of years, what's happening here in the UK and really around the world with opiates. So we may have to turn this music down just a little bit when you come back. But let's go ahead and do this for just a second. And I'd like you to read the words and listen, and then we'll move on. And some of it's a little graphic, so I apologize ahead of time. But it's where we are in our state of society.
Said it wasn't a gateway drug. My homie was taking subs and he ain't wake up the whole while. These billionaires stay caked up, paying up Congress so we take their drugs. Murderers who will never face the judge. And we dancing to a song about a face gone numb. But I seen homies turn gray, noses draining blood. I could have been gone, our 30s faded in that tub. That's Prince, Michael and Whitney, that's Amy Ledger and Pimp C, that's Yams, that's DJ AM. Goddamn, they're making the killing. Now it's getting attention cause Sarah, Katie and Billy. But this shit's been going on from Seattle out to South Philly. It just moved about the city and it spread out to the burbs. Now it's everybody's problem, got a nation on the verge. Take activists off the market, jack the price up on the syrup. But Purdue Farmers about to move that work.
The drug dealer was a doctor. Doctor had the plug from Big Pharma. He said that he would heal me. But he only gave me problems. My drug dealer was a doctor. Doctor had the plug from Big Pharma. I think he trying to kill me. He tried to kill me for $1.
And these devils, they keep on talking to me. They screaming, open the bottle. I wanna be a piece. My hand is gripping that throttle. I'm running out of speed. Try to close my eyes, but I just keep on sweating through these sheets. For a horseman, they won't let me forget. I wanna forge a prescription, cause doctor, I need some more of it. When morphine and heroin is more of your budget. I said I never use a needle, but sure, fuck it. I'm caught up, I'm on one, I'm nauseous. No options, exhausted. This is not what I started. Walking carcass, I lost everything I wanted. My blinds drawn, too gone to leave this apart.
My drug dealer was a doctor. Doctor had the plug from Big Pharma. He said that he would heal me. But he only gave me problems. My drug dealer was a doctor. Doctor had the plug from Big Pharma. I think he trying to kill me. He tried to kill me for $1.
Re-up, death certificate signed the prenup. Ain't no coming back from this Percocet activist, Ambien, Adderall, Xanax binge. Best friends with the thing that's killing me. Enemies with my best friend, there's no healing me. Refilling these. They say it's debt, institutions and DOC. So God grant me the serenity to accept the things I cannot change. Courage to change the things I can. And the wisdom to know the difference.
So he is in recovery now and speaks all over the country, really all over the world now, about his addiction, which is pretty amazing. And he goes to both NA and he also goes to Chronic Pain Anonymous because he continues to have pain in his wrist. But he learned how to deal with his pain in a very effective way. But that song really represents a lot of what happened. When he went to the physician, he went to the emergency room and they prescribed 360 hydrocodone. It's not just because he's Macklemore, it's because he was hurting. It happens all the time in patients that I see. And the way that, we'll talk about the way that we got there in just a little bit, but he's correct. Purdue Pharma, the family that owns Purdue Pharma, they're the 5th wealthiest or 6th wealthiest family in the United States, and their net worth is about $75 billion, and about 75% of that is based on OxyContin revenue. And they are over here much more now because the United States is cutting down, thank goodness, and we're controlling it. Almost 300 million prescriptions were written in 2012. That was 4 or 5 years ago. 4 out of 5 heroin users report that they started with a prescription. In 2015, more than a third of all adults in the United States were prescribed opioids. We have about 325 million people in the country, and about 133 million have chronic pain, and many of those were prescribed opiates the first time they went to their family practice doctor. So we're experiencing about 142 opioid-related deaths every single day in the United States right now. So I looked into, when I was invited to come speak, is this happening in the United States? And I had been doing a little research prior to that. So I learned that about 3,700 people died of drug poisoning in 2017 amid the use only of synthetic opioids and fentanyl. That's almost 4,000 people in 2017 that died from synthetic opioids such as Suboxone, overdosing on Suboxone or fentanyl. More than 50% of, that's an error there, of the deaths in the UK were related to overdoses involving opiates, then followed by benzos, cocaine, and amphetamines. So how did we get started with this in the United States, and how do I think it came over here? I think that in the United States, the way it really started, heroin use goes way, way back. We all know that. But in 2000, President Bill Clinton, I think with all the best intentions in the world, signed a bill into law. And that law said that every healthcare provider in the United States not should, but must assess and treat for pain appropriately. So the word must was key in there, not should or can or may, but must. And then they said, if you don't address pain properly, we're going to take your federal funding away. You're not going to be able to bill Medicare, the federal government, the Medicaid, your state government, and then if you can't bill Medicare, your private insurance carriers will take it away and you'll be out of luck. So you better take care of people in pain. So from that year forward, every single time you go to a physician, whether it's your family practice doctor, an emergency room, or any other type of healthcare provider, one of the first questions they are is, what is your pain level? And they say, what is your pain level on that silly Likert scale from 0 to 10? This is 2018. With all the technology we have in the world, the only way we measure pain today is a scale from 0 to 10, or a happy face to a crying face. In 2018. So if we all huddle after this and meet for a few days, maybe we can come up with a tool and we'll never have to work again that will appropriately measure true pain. So again, doctors began prescribing opioids liberally in the late 1990s and then in 2000, early 2000 when Bill Clinton signed this. And doctors began to say, I want you to take one of these every day until I think of something else. Because when we hurt, and you have back pain and I have back pain, we feel that pain very differently. It's very subjective. My level 1 pain and my level 5 pain are very different than each one of your level 5 pain or your level 1 pain. We all perceive it differently and we all feel it differently. So when you go to a physician and they do x-rays and MRIs and imaging and they don't see anything and they can't find an organic cause for pain and they have 50 patients a day to see, the easiest thing to do is what? Write a prescription and say, I'll see you in a month. So keep going on this past this one. So the Washington Post, I'll just talk about this for just a second, said in 2015 more than 33,000 people died from overdoses from opioids, meaning prescription painkillers, heroin, fentanyl, or any combination thereof. And of course, something huge that's happening both in the UK right now and in the United States is is that if opiates are too hard to get a hold of, guess what's really easy to get a hold of on the street, and that's heroin. So in Charleston, they reported that opioid wholesalers shipped, this is just amazing, 780 million oxycodone and hydrocodone pills to the state of West Virginia. The state of West Virginia is about as big as this room. And they shipped almost 800 million 800 million oxycodone and hydrocodone pills. That's enough for 433 pills for every person in the state of West Virginia. But again, one of the things that happens when people go to the doctor is when people are in pain, they don't feel heard. They often come to me and say, even in the exhibit hall outside, are you here because you think it's in patients' heads? Well, I do think it's in your head, and I think it's in your head because we have this very intelligent brain in our head, and we know that we're in pain. But a lot of times physicians get sick and tired of their patients because, quite frankly, they go to school to heal people. I know that they want to do the best that they can do to take care of people, but when they're out of options, they get frustrated by you coming back and coming back and coming back and saying, I'm still hurting. So what is pain? Obviously, pain is probably everyone in this room understands pain. Pain is when you touch a stove and it's hot. Pain is when we step off a curb and then we sprain our ankle. And it's an immediate sensation, and it's a signal that's sent from our spinal cord to our brain that says, your ankle is sprained, your ankle is hurting, take this finger away from the stove, right? Chronic pain, and pain again, one of the most important things I'll say that you all know, pain is 100% subjective. I cannot tell you what level of pain that you're in. And I believe you when you tell me that you're in a level 8 or 9 pain or 10 pain. So if one regards their experience of pain and if they report it as pain, I'm not anyone to judge that they're not in pain. But what we can do is work with that pain, especially when it becomes chronic. So pain will go from an acute phase to a chronic phase sometimes, not all the time. And it goes about, out of everyone that experiences an acute phase event, 75% of those people will heal within about 90 days. Our bodies were designed to heal, no matter if it's a broken bone, a tissue, or what have you, we're designed to heal in about 90 days. I'm fortunate enough that one of my patients says that I can talk about her at any time and any place. So I'll talk about her for a second, and that's Congresswoman Gabby Giffords from the state of Arizona, who was shot 6 times in the head and in the upper torso of her body when she was giving a talk in Tucson, Arizona. And they rushed her to the hospital and saved her, stabilized her, and brought her to Houston to one of our trauma hospitals. And she was there, and she was my patient for about 1.5 years after that. And she obviously went from an acute phase to a chronic phase. Her body was supposed to heal within about 90 days. And for the most part, a lot of her trauma ended in that 90 days. But her nervous system continued to respond, and she fell in it. It's pain pain that goes beyond that expected tissue healing time. It changes the pain signaling. And I often say that a chronic pain signal is a faulty wiring of our nervous system. It's just a faulty signal because, quite frankly, there's really no purpose for chronic pain at all. It's a misfiring of a signal. So the difference is between chronic pain then and chronic pain syndrome is that many of us have chronic pain. I've run 28 marathons, and I love to run. I've been running in Hyde Park almost every morning, which I absolutely love. But my back has a little twinge in it, quite frankly, right now. And my knees hurt a little bit when I wake up. And I'm sure that some of you, we're also aging, right? And our knees crack and our backs hurt. But we get up and we go to work, right? Most of us function freely. And we do the things in life that we want to do. I'll go to Hyde Park and run even though that I know my knee's going to hurt or my back is going to hurt because I know it's good for me. So I'll try to continue to function. But of that 25% of people who don't heal, that go into a chronic phase syndrome, into a chronic pain state, about 13% of that population falls into a chronic pain syndrome. And the simple way to talk about chronic pain syndrome is quite frankly, it's a failure to thrive, right? We begin to experience depression, anxiety, we withdraw from society, we withdraw from going to dinner, to the movie, to the theater, and doing the things that we love to do, and we stop working many times. We're not intimate with our partners because our back hurts and we're afraid that it's going to continue to hurt, or whatever that symptom is. Mostly anxiety and depression. So what do we do about it? And what's the proper assessment for someone with chronic pain? I believe that once it becomes a chronic pain syndrome beyond that 90 days, the earlier the intervention, the more likely, of course, we are going to have success and see success in life, and allow someone to get back into thriving in life. So what is always recommended, usually by the time I see someone, they've had pain for up to 10 years, 3 to 10 years, and their lives are completely out of control. But in the patients that we see early, at that day 95 or 120, what have you, doing a complete medical and psychiatric evaluation. Most of the time after 90 days, patients will tell me they've had their MRIs, they've had their x-rays, they've had all of their diagnostics, they've been to an orthopedist or a neurologist or a pain doctor, and nobody can figure out why their pain is continuing to signal. So we like to do a full medical evaluation and look at lab work, look at vitamin D. If most people with chronic pain have a vitamin D deficiency, a lot of people have vitamin D deficiency, but it's especially active in the chronic pain. So we also want to do a full psychiatric and psychological assessment. And I want to look at, what do we do? How do we function? And how did that pain interfere with our life? How is pain interfering with my life now? Again, sleep, anxiety, depression, fear, kinesiophobia, things like that. Work, that's part of psychosocial assessment. We want to look at an addiction history. Have they misused their medication, or are they using it like they should? And I also believe, I did a clinical rotation at Mayo Clinic in Rochester, Minnesota, and I'll give a plug to their pain program. It's an amazing, one of the world's best pain programs in Rochester, Minnesota. They take about 50 patients a month in their pain program. It's the only program in the country that our state, our federal government, Medicare will pay for. And Dr. Hooten, the medical director, taught me 21 years ago that if an opiate hasn't worked in 90 days, it's not going to work in 91 days, and it's not going to work in 10 years. And so the Mayo Clinic drilled in my head, and thank goodness I continue to have this philosophy, that they believe that an abstinence-based approach to chronic pain is the best way to treat a pain patient. So I treat all of my patients in an abstinence-based, and if I'm not quite as rigid as Dr. Hooten at Mayo Clinic believes that on day 91, he's not going to give you an Advil, a Tylenol, or an aspirin. I'm not quite that severe, but Dr. Hooten is. But absolutely no opiates after 90 days. If it hasn't worked, it's just not going to work. And how many times, I don't know if anybody in this room works with pain, I'll ask you in a second, but when you interview a pain patient, oftentimes they say, my pain has been a level 9 or a 10 for the last 3 years. What is the medication that you're taking? Well, I take 180 milligrams of OxyContin, or I'm taking hydrocodone, or I'm taking a combination of hydrocodone and OxyContin, and they're taking a benzo for anxiety, and they're taking something to go to sleep at night. And unfortunately, sometimes in the morning, they're taking Adderall to wake up and try to function during the day. And they're still reporting a level 10 pain. So when you talk about taking away that pain medication or that opiate from them, we have that instant fear, that flight or fight response. And they don't want to detox from it. So we'll talk about that in just a second. But what happens with someone is pain yields an increase in anxiety. And anxiety increases the amount of pain that we feel, right? We're not coping with it, and it causes increase. We have worries about employment, worries about our general health, work, medication worries. Am I still going to get my medication? Is the doctor going to refill my medication? Am I going to have surgery? Am I going to be able to function and have intimate relations with my partner? So what I want to stop and pause here and say is that we have, obviously, I'm speaking to an intelligent group of people, so bear with me. Every nerve ending in our body connects to our spinal cord. And every spinal cord nerve goes up the spine to our brain, and that's the only way we perceive pain. And when we're anxious, it increases the amount of movement in our spinal cord and in our nervous system. And the more nervous we are, the higher level of pain that we're going to feel because our nervous system is activated. When I flew over here, I didn't sleep well on the airplane, and the next day I wasn't quite functioning really highly. And when I don't function, when I don't get 6 hours of sleep at least, I like to get 8, but when I don't get at least 6 hours of sleep, the next day my hands trem. I have a little tremor in my hands, and I can just tell I'm not on the top of my game. And if I had chronic pain, then that would greatly increase the amount of pain that I feel. When we're depressed and we're feeling, sometimes we have active or passive suicidal ideation, it increases our nervous system movement. And the more moving and the more movement our nervous system twinges, the higher level of pain we're going to feel. And then what do? We brace and we hold our body and we hold all of our muscles. No matter what part, if your knee is hurting, you still go like this. If your foot is hurting, you still go like that, right? And it causes tension all the way down the spine. And when we cause tension in our body, our pain level goes through the roof. And it's just this vicious cycle. So go ahead. So when we do it a lot. Keep going. So these are a lot of the things. It limits our thinking. Pain and stress limits our thinking. We're not able to think. It really increases our blood pressure. It increases our breath rate. It really decreases our breath rate because we're going short, right? It decreases the absorption of nutrients, increases our blood sugar, increases sticky platelets. Of course, it decreases our immune system, causes infertility, high muscle tension, again, depression. We don't eat right because we don't feel good, right? And we want comfort food, and we want something to make us feel good, so we'll go dip an Oreo in milk and eat it. And it makes us feel old. So you have someone in chronic pain, and this is what I hear people tell me every day in very simplistic terms. Am I imagining this pain because my doctor doesn't know what to do? I've been to the best surgeons in the United States, and they don't tell me what to do. I can't stand this. They should cure me. You're a doctor. You need to figure out what to do. There's got to be a pill or there's got to be a surgery to do this. I can't do what I used to do, and I'm never, ever, ever going to be better. I'm never going to be able to play with my grandchildren. I'm never going to be able to pick up my children again and play with them. And I'm never going to be able to shop like I used to or go on vacation like I used to, and I'm going to sit at home. And they begin before living a happy life. And when I'm talking about pain, I'm talking about someone who may have as simply, it's not simple, but I'll say simply a migraine headache. Someone may come to me with migraines and have every one of these feelings. And then I had a woman that was sitting on her porch in front of her house, and it was about, their house was about 6 feet off the ground, elevated, and it was this beautiful brick, wonderful porch, and it was a beautiful spring morning, and she was kneeling down like this, and she was picking something up, and she had this wonderful 2-year-old black lab, and the little black lab puppy came and jumped on her back, and it pushed her, and her balance got off, and she felt like that before, and she fell, and she fractured 4 cervical discs in her spine, right? 1 minute she was like this, and 6 years later, she was in my office because she had had 21 surgeries on her neck and ended up suicidal, been to 2 psychiatric institutions because of wanting to kill herself and not living life, and felt every one of these feelings. So you never know where pain is going to come from. It can come from a migraine headache, from fibromyalgia. It can come from falling off a porch. It can come from a car wreck. It can come from anything. So what are the domains of pain? Of course, lots of psychological morbidity. Simply doing a Beck depression inventory, which is an assessment that you can get online now. Most patients with chronic pain will score in the high, moderate to severe range of depression. We see over typically severe anxiety, lots of anger. Most people, interestingly, a chronic pain patient on average will tell me they get about 1 to 2 hours of sleep a night. I know I can't function on 6 hours. I think they're probably sleeping a little more than 1 to 2 hours, but it is a consistent theme throughout almost every pain patient we see that says they sleep about 1 to 2 hours. But what really happens is they're up and down all night long, up and down, and they're pacing in their house, or they're laying in bed and they're twisting and they're turning and they're trying to get comfortable. And they lose their self-esteem. Stop putting makeup on, stop doing their hair, stop dressing the way they normally dress, really stop caring about life. Healthcare costs dramatically increase. Many people file for long-term disability. Of course, there's millions of lost work days, and that causes marital and family relationship problems. Again, intimacy. One of the biggest complaints I get from both males and females in an individual session on an initial interview is the loss of intimacy with a spouse. And when we're interviewing family, which is critical in a pain program, the family members, or not members, the loved one, the biggest complaint is a loss of intimacy. Again, social isolation, loss of recreation and ability to perform activities. So the first time people sit with me, they say it is in my head, and I say, yes, it's absolutely in your head because of that beautiful brain that you have. Why do I need to see a mental health professional? Why do I need to see a psychologist or a psychiatrist? Because my doctor can't help me and he thinks I need to come see you because I'm crazy. And 99.99% of the time over the last 20 years when I see a patient, they say, damn it, this pain is not psychological, on the first visit anyway. Cultural factors. Interestingly, in 26 years of practice, I've treated literally thousands of patients in the United States. Houston, Texas is, I don't know if y'all knew this, Houston, Texas is the most diverse city in the United States. It's pretty wild. I really thought it was New York or San Francisco.
What did you say is the most?
Houston, Texas is the #1 most culturally diverse city in the United States. And I live half time in Houston and half time in Austin, Texas, but I've lived in Houston for 35 years. And guess how many Asian patients, chronic pain patients, I've treated in my practice? Anybody have an idea?
Very low.
1. In 26 years, I have treated 1 Asian male, and it didn't go so well. But acupuncture, right? Because they manage it in a very Eastern philosophy, and they don't go to pain doctors like Americans go to pain doctors. And now what I'm seeing in the UK, they don't have that instant gratification of wanting instant gratification, of saying, I have to have a pill, or I have to have this now. So go ahead. So the rate of depression and chronic pain is, I think it's more than 4 times. But Harvard says it's about 4 times as high as those with, in the general population. Depression is repeatedly found to be one of the biggest predictors of pain intensity. Again, this is from Harvard Mental Health Newsletter in December of 2017, and I have that article if you'd like it. I know, exactly, there's an Asian, right? I did use an Asian woman on that. It was just such a good photo. We always see depression with chronic pain. Rarely do I ever see a patient, chronic pain syndrome, do I ever see a patient without depression. Go ahead. Lifetime prevalence is higher in low back pain than for the general medical population. Many times an insurance company will ask me if it's an insurance patient, not a private pay patient, will say, is this a mental health problem? Is it anxiety? Did they have anxiety before this? Because if they did, we're not going to pay for pain treatment. Which came first, the pain or the anxiety? Who knows, right? Sometimes we're born and we have comorbid psychological disorders, but for me it doesn't matter which came first. Go ahead. Clinicians many times see chronic pain patients as very angry. And I'm talking about psychologists who don't have pain experience. Many of my friends and colleagues are psychologists. Many of my friends and colleagues are physical therapists, doctors of physical therapy. In hiring staff, one of the hardest staff members to hire in a chronic pain treatment program is a physical therapist. They hate chronic pain patients. They just don't like working with them. And I hate to, is there any physical therapists in here? They just don't like it because they're more sports-minded and they want to heal quickly and they want to get someone back on the road and down the road in recovery. And so they see patients as very, very angry because also chronic pain patients typically quit going to physical therapy about 2 days into treatment, sometimes a week into treatment. And when anger is present, it exacerbates depression and it intensifies pain, right? So we always want to accept their report. We see a lot of fear and avoidance, right? Patients want to avoid cutting the yard, they want to avoid going to work, they want to avoid doing anything that's going to hurt their back, their knee, their head, give them a headache, exacerbate their pain, or cause a pain flare-up. So there's lots of fear and lots of what we call kinesiophobia, which is a fear of movement. Because the more I move, the more I'm going to hurt, right? These beliefs are much more disabling than the pain itself. And we'll talk about that. And overwhelmingly, chronic pain patients catastrophize and use words like never. I'm never going to feel better, and this pain is never going to go away. And a doctor is never going to be able to help me because I've seen 100 of them and it just isn't working. So again, just show you another visual of that pain cycle. They guard and they begin to have muscle spasms. When we guard and we sleep tight in bed, we're going to have a muscle spasm at night. Our back is going to spasm or our calves are going to spasm, and it's going to increase the amount of pain that we feel. And when we do that, when we restrict our movement, our muscles begin to atrophy, right? And it begins to weaken. So Walmart, y'all know what Walmart is. Walmart bought every single employee in the United States a back brace and said, we're going to make every one of our employees wear a back brace because we're going to cut down on our injuries and we're going to cut down on the amount of work-related injuries that we see. And in 1 year, their injuries tripled because wearing a back brace weakens the back. When you wear a brace, it weakens the muscle. Right. So stay away from back braces. They're good for a certain time, post-surgically maybe, right? When you're in that acute phase. But after that acute phase, it does nothing but make your muscles atrophy and your body atrophy. And we lose functioning and we get angry and the pain increases. So again, that catastrophizing. Pain patients' behavioral function begins to be compromised. Their emotional functioning is affected. Their beliefs are strongly associated with their emotional functioning. And acceptance appears to play an important role in emotional. We talk about a lot in treating patients something called radical acceptance. And we want them to begin to accept their pain for what it is. Legal issues, sleeplessness, lack of intimacy, we've gone through all of that. We see a lot of trauma in chronic pain patients. With or without back surgery, about 76% of patients with low back pain report having one trauma in their past. We see a lot, about 33% of the patients at the University of Washington who went through the pain program who were female reported on the first visit with their psychologist and psychiatrist no past history of sexual abuse, but within 2 weeks, within that program, they began to discuss their sexual trauma from early childhood. We see a lot of early childhood or young adult sexual trauma. 90% of women with fibromyalgia report childhood or adult trauma. 60% of those with arthritis report trauma. 58% of migraines. Men and women report sexual abuse and neglect. And women with chronic pelvic pain are rate very highly on the sexual abuse scale. The presence of chronic pain strongly suggests that medical interventions are not going to be effective. So there's a device that I just met with a pain physician here in London the other night. Is the president-elect of the London Pain Society or the UK Pain Society, and he implants about 400 spinal cord stimulators a year in patients, and that's about a $60,000 device that is about this big around, and they implant it right here under your little abdomen with a lead that goes around to your spine, and it gives us a little electrical impulses. And the intention is for it to interrupt the pain signal and say that, and it's supposed to tell us it's effective about 30% of the time. And in the United States now, prior to doing a spine surgery and prior to having an intrathecal pump, which is morphine or a spinal cord stimulator, they must be cleared by a psychologist or a psychiatrist saying that they're appropriate for that surgery. Effective treatment programs incorporate the practice of mindfulness, which we'll talk about in a minute. And again, early treatment, I think, is just fantastic if we can get it. Go ahead. So what we want to do is we want to have a paradigm shift. And we want to move people from cure me, because that's where they come from, is I want you to fix me, to being more of an active participant in their own lives and taking control of their own lives. So the first thing that we do is we talk to patients or prospective patients about detox, and it scares the heck out of them. And sometimes they run, and then they come back a couple of days later and say, tell me a little bit more. But we'll use Suboxone for about, depending on what they've been taking. Methadone, we see patients on 120 milligrams of methadone who are going to require longer-term Suboxone. But most of our opiate or benzos, or opiate and benzos, will take Suboxone for about 4 to 5 days, sometimes 10, while they're in the program. But the shorter the better for me, as long as we watch for seizure activity and potential seizure activity and prescribe appropriately for that to reduce the potential for seizures. But we always detox. One of the things that happens to us when we take opiates over a long period of time, and when I say a long period of time, I really mean about 90 days, is our brain and our chemistry in our brain begins to change, and we experience something called hyperalgesia. And hyperalgesia is a term that simply means, are there physicians in the room? Anybody? Yeah, I thought you might be a physician, so you know what, you can explain hyperalgesia. It's better than I can. But hyperalgesia decreases our tolerance for pain, and it increases our sensitivity for pain, right? It changes the way that we feel about pain, and it makes us feel like we're actually in a higher level of pain. Do you have anything to add to that? Exactly. Absolutely. They feel like they need more and more pain medication. They need more opiates because their receptors have been put to sleep over that short period of time. So when you're talking to a pain patient about detoxing them, and they have this fear, and everyone has a fear of going off of a pain pill, and they think, I'm in a level 8 pain now, how am I going to feel when you take me off of everything? I'm going to feel worse. In about 4 days, they actually feel better. We see typically about a 20% reduction in pain after only about 4 days in a detox program, right? It's just amazing. And then when they're finished with detox, we see a slightly decreased pain level again. And it is absolutely amazing to see someone who's been on pain medication and opiates for 10 years or a year, who after post-detox will look at me and say, I cannot believe my pain's not worse. I'm still skeptical that this is going to work, they say, but I'm going to give it a try. So we offer residential, partial hospital, outpatient, and extended care. Certainly, again, the medical and psych evaluations, individual and group therapy, family work. I'm going to show you real quick where we do this, and then I'm going to talk more about how we do it. So this is our property. We're in Austin, Texas, about 25 miles outside of Austin, Texas. You can just kind of scroll through. We have breakfast and lunch out here. One of the best parts, I believe, about working with a chronic pain patient is when our back hurts, and I'm standing here on concrete, right? It hurts more. But when you float in a saltwater pool and we're more buoyant and it takes the weight off, or someone in the U.S., when we're heavier, we have a lot of weight right here and it pulls on our spine, so we feel more pain. And when they can float in that pool and move their arms and their legs more freely, we see great, great results from it. Comfortable setting. Just the entrance of our property. So what do we use when we treat someone? I think something extremely important is using acceptance and commitment therapy. Again, because when you're working with someone in chronic pain, they feel like they haven't been accepted. And they feel like they've been rejected over and over again. And many times they feel like they've been rejected by their husbands, their wives, their children, their loved ones, by God, by anyone, by their employers. And they just don't believe and have faith in you yet. So by using ACT and acceptance and commitment therapy, we have really good and grow quick bonds with our patients and residents. I like to use cognitive behavioral therapy because when people come to me, again, it's that catastrophizing mode of I'm never going to be better. And I like to do a paradigm shift in using CBT by saying we're going to change the way you think about your disability. We're going to change the way you think about your pain. DBT, of course, motivational interviewing, adventure-based therapy. So one of the first things that we do with a chronic pain patient after they've had a physical evaluation and we know that they can do this and it's not going to hurt them is, on that beautiful property that you saw, we go canoeing and we go kayaking and we have about 5 miles of walking trails and running trails, and we have a high ropes course and a low ropes course, and I believe that you have to move. You've got to move. My lovely old grandfather, who is no longer with us, and God bless him, he died and practiced until he was 92. I have his medical bag. It's an old black alligator medical bag, and it's the most prized possession I own. But I remember in the summers I would go to his office with him, and he would talk to his patients. And if they had back pain, he'd say, "Go rest for 2 weeks. Go home and lay down and rest for a little while." That's old school thinking. We now know, look, my mother-in-law had open heart surgery, and that afternoon she was walking down the hall, right? When we have surgery, when you have a knee replacement, they put that constant motion thing on there and they start moving it that afternoon because we need to move our bodies. And when we have chronic pain and there's no identifiable reason for that pain, we need to move. So one of the first 2 days after they do a full physical assessment is we go get in a canoe. And almost every time they say, you want me to step down in that canoe and row? Yep, we sure do. Absolutely, I can't do it. Can't do it. Just get in and I'll do it. I'll do it. You just sit back there. I'll take care of us and just go. And we'll start going down a creek or a little river, and in about 15 minutes, probably less, all of a sudden I feel the speed going a little bit faster, and I kind of glance back, and they're rowing. But if you turn around and look, they'll stop rowing. But we always want people to move, and so we use a lot of outdoor activity, lots and lots and lots of outdoor. We even do therapy outside when it's not 95 degrees. And the core of the program, I believe, because of the addiction related to their pain medication, most patients come in with chronic pain and say, this is a medical issue, I'm not an addict, right? But after about a week, they go, oh, I really am. And so the core of our program is based on AA and NA, and it's a 12-step facilitated program. What are you doing? Oh, okay. All right. Thank you. Did someone call my name? Yes.
I'm wondering if you do anything specific in terms of the modality of treatment related to trauma.
We do, yeah. So he asked the question, do we do anything related to trauma? We have 2 trauma therapists on site full-time. Trauma is a huge part of pain, especially for someone like Gabby Giffords, right? Someone that was shot 6 times. But when you have fibromyalgia, there's trauma related. When you have early childhood sexual trauma, there's a lot of it. A lot of our patients, by the way, come to us with a diagnosis of bipolar, right? And they come in and their families say they've been diagnosed with bipolar or borderline personality. And after they've been with us and we do our psych assessment, our full psych, they didn't have bipolar disorder. They're not borderline, right? Sometimes they're not. Sometimes they are. But we absolutely do a lot of trauma. So we'll walk through this. So we always want people to get moving, have fun outdoors. We talk about stress. We do mindfulness, challenge by choice. So keep going. We do programs 7 days a week. I believe Monday. By the way, I know you're taking pictures, and that's fine.
I know we will get it.
Yeah, I'm going to give it to you. I'm going to give everyone my email, and you're welcome to have it. I always want to ask in a pain assessment what they like to do and what they want to do, where they want to go. And the other question I think is important. When you have someone that's had chronic pain and they're rating their pain level at an 8 or a 10 constant, one of the best questions you can ask a patient on day 1 is, what kind of relief would make you happy? What would you accept? You'd be shocked at people will say 10%. 10% will make me feel better. If I could just get 10%, 20%, 25%. Sometimes people say 50%, but rarely does someone say 100% or 70%. It's somewhere between 10 and 50% most of the time. And by doing the activities that we're going to talk about today, we literally see patients leave oftentimes with zero pain, that continue to have zero pain 3 years post-treatment. And sometimes they leave with between a 1 and a 3, but they think about it so differently that it doesn't even bother their life, and they do many things. So always ask them, what kind of relief are you expecting? Keep going. So we use also something called a Neuro Lumen. You can Google the term Neuro Lumen. It's a company out of Oklahoma City. This device costs about $900 to use it for yourself, or it costs about $2,000 for because we treat multiple patients with it, and it's a little bit bigger. But this is a combination of a TENS unit, a low laser therapy, and light therapy. So it's 3 different techniques used in one, with pads, with gel pads that you put near the injury, and it draws circulation to the area. And when you draw oxygen and blood to the area, you have a decrease in pain, right? And it just helps. We see so much relief from this. It's just an amazing little device. Our pain physician, we have an interventional pain doc who's, of course, boarded in interventional pain medicine. He's an MD, but he's also a naturopath. He's boarded in nutrition. He's a black belt in Qigong, I think, Qigong and Tai Chi, if those are black belts. He's the highest level of training. And he does lectures weekly with the patients. They also have a one-on-one with our pain doc twice a week. And every single morning we started off with morning reflection with all of our clinicians and ask what the goal for the day is. We do a lot of mindfulness and a lot of breath work. You can't heal when you're stressed all the time. So we talk a whole lot about mindfulness and a whole lot about stress reduction, because the more stressed we are, the more pain we're going to have. So we do lots of meditation, lots of relaxation and visualization. Someone may like to be in the mountains, and someone may like to be in a lake or an ocean or what have you. And this is really good with irritable bowel syndrome, TMJ, arthritis, fibromyalgia, migraines. All these 2 right here are amazing with IBS.
What's TMJ?
Transgeminal, it's where your jaw is, where you have so much pain. Muscular, yeah, thank you. Mandibular joint, yes. Temporomandibular joint, yeah. Keep going, we don't have time for that. So, overview of some of our techniques. Teach people progressive relaxation, starting with your fingers and your toes, right? We're all in that fight or flight response when we're in pain. And when we're in pain, by the way, we're in a state of anxiety and stress. And when we experience the fight or flight response, all of the blood in our body stays about right here, right? And you always see patients with cold hands. Pain patients have cold hands and cold feet because they're stressed and the blood circulation comes up here. And that's from that old fight or flight response when we were trying to escape the tiger, right? So that if it scraped our legs, the blood was here and not down here, right? So breathing exercises. So many people breathe from here. And artists and singers breathe from down here, diaphragmatically. And when we breathe diaphragmatically, it pushes the blood and circulation through our entire body better than it does just right here. Lots of physical exercise, which is one of the scariest things that a pain patient can do. Daily yoga, 2 times a week, Tai Chi or Qigong. Biofeedback, again, because we have pain patients have cold hands and cold feet. And we have little bitty, you can get them on Amazon, and all you have to Google is skin temperature meter. Skin temperature meter on Amazon. It's like $3. It is amazing to put this little thing on someone's hand with chronic pain, and the exterior temperature will read about 68 to 72 degrees. And you let them see that visually. And then you walk them through a 20 to 25 minute visual exercise of allowing the blood to flow and talking about the sun shining or the lake or the ocean or what have you. And then in about 20 minutes, you look at it with the patient again, and it's about 89 degrees. It is amazing, and they just go, what the heck are you doing? And it's just a simple little technique. So that's biofeedback. You know, massage is a passive modality, right? Or is it passive? It's an active modality, right? It's kind of sitting there, right? We want to teach people self-massage. We don't want them to have to go to a massage therapist all the time because it's expensive, right? But we do want to teach them that massage is important. Guided imagery, self-hypnosis, cognitive techniques. Music is huge. We treat a lot of musicians in our program that have been on tour who have been addicted to opiates. But the other thing is we treat the spirit. We talk about self-compassion, connecting with others through socializing and shared interest. We talk about prayer, whatever that means to them, meditation. We also treat a lot of the patients that I treat are high net worth individuals. That's not everyone at Driftwood. It's just because I've been doing it for 26 years, somehow I am referred a lot of people who come from very high net worth families. And this is one of the most important things because they don't work and they don't have any purpose in life and they have to volunteer. One of my pain patients, just real quickly, was with me for 9 months. Our average length of stay is 62 days. One of them was with me for 9 months. She had never had a job in her life. She was 42 years old. Never worked a day in her life, had done anything. And after about 3 months, I said, you either have to go or you have to get a job, or you have to volunteer. And she got a job at Mama Foo's fast food Chinese delivery. And she was delivering food one day to the W Hotel in Austin, which is obviously a really nice hotel in Austin. And she was on the 21st floor in her Mama Foo's outfit, right? And she got on the elevator and she was coming down and it stopped on the 10th floor and the door opened and it was 5 of her high school girlfriends. And she was like, he made me get a job. I have to work. But you know what? She's been gone now for about a year and she works in the treatment industry as a care coordinator making $12 an hour and loves it. And she's helping people with pain. And it's just amazing. Her pain level when she came in had been 9 for about 3 years, 4 years, and now she has 0 pain. Again, a lot of slow movement. Every single morning we get in a circle. And if the weather is nice, we do it outside in this beautiful garden. And if it's so hot or rainy or something, we do it inside. But we start with our fingers, literally, with really great music. And I lead them, or one of our therapists, if it's not me, leads them through an exercise doing this. And we literally move every part of our body. And then we bend slowly and we move. And that's the way we start our day. And we do a reflection every morning. Keep going. Yeah, music is huge. It's just an important, critical point of what we do. Acupuncture is important. We use a lot of auricular acupuncture. Dr. Jimenez, who's our medical director, is boarded in several different types of acupuncture, but his favorite for chronic pain is using auricular acupuncture, and it works just fantastically with chronic pain patients. Again, massage. We have a physical therapist, naturopaths, osteopathic physicians, and a chiropractor who work with low back pain and every other type of pain, really, but it's great with chronic low back pain. Back pain is the most common type of pain that we see. Aquatic therapy for buoyancy, again, is just absolutely amazing. And getting outside, this is not Driftwood, by the way, but it's really amazing to get people out who haven't been doing something. This is Connie Cole, who is our physical therapist who works with our patients. And we have 21 of these bicycles that she takes people out on biking trips who think, I could never get on a bike in my life. Adventure-based strategies that we've talked about. This is part of a high ropes course for with our chronic pain patients. We go zip lining. We have a beautiful greenhouse that we grow. We grow all of our fruits and vegetables on site, and it's great. This is an employee acting like a patient that does this, but we work with plants, and just putting their fingers in the dirt and working and watching something grow is amazing. We have 3 chefs. Nutrition is huge in chronic pain. There's all types. I'm not going to go through them today. I'll be happy to email them to you. We use organic foods, but we use a lot of turmeric and a lot of ginger, a lot of beets, and a lot of cherries. Cherries are a huge anti-inflammatory that really work well with chronic pain. We drink smoothies every morning that are anti-inflammatory and antioxidant smoothies. And nutrition, again, for chronic pain. I know in my country, unfortunately, when people want comfort food, they eat fried foods, and it's one of the worst things that you can do. Smoking is also one of the worst things that you can do. It activates the nervous system, and when we all know with an activated nervous system, we're going to have more pain. So some of the things: red pepper, dark chocolate, black beans, broccoli, olive oil, chia seeds, nuts, and green tea, all excellent with chronic pain. I think we'll go back to the PowerPoint now. So family is so important when working with a chronic pain patient, because in chronic pain patients, there's a lot of secondary gain, right? So when you have chronic pain and it's acute at first, your husband or your wife or your loved one says, "Don't worry, I'll do this for you." And then it becomes chronic, and they're still saying, "Don't worry, I'll do this for you," but it quickly transitions into them not asking if they can do it for you or not worrying, but you expecting it. And so many chronic pain patients, when it goes into that syndrome, expect their families and their employers and other people to do things for them because they hurt, and it's a lot easier. It's easier to sit there than it is to get up and cook dinner. It's easier to sit there than it is to wash the dishes or do something. So family is a big part. We do a 4-day family program, and I think all programs that work with, all programs period, but especially with chronic pain, should do a 4 to a 6-day, 5-day chronic pain family program. Keep going. So I just wanted to talk for a minute about mindfulness. Mindfulness is the awareness that emerges through paying attention on purpose. And it's paying attention about what's going on this very second. Not what I said just a few seconds ago, and not what I'm going to say in a minute. And with chronic pain patients, they grieve over the past, and they worry about an hour from now. And they grieve over the past, and they worry about next week and next year. And so it's really, really important when we're talking about acceptance with chronic pain. It's hard to believe that you can talk to a patient about acceptance and saying, "I want you to accept your pain no matter how bad it is." But when they begin to accept it and they think about now, not yesterday and not tomorrow, we see decreases in pain after we begin to practice mindfulness and that deep breathing. So we talk about acceptance as paying attention with intention. Because when you're learning how to do mindfulness, I remember when I learned how a long time ago, it was really difficult. And you have to have intention. You have to focus on what's going on right now. And you have to do it with a positive attitude, because if you have a bad attitude about it, your mind's just going to go all over the place. And it's a lot easier to think about negative things than it is positive things when you have chronic pain, right? But mindfulness simply has great ancient roots. It goes all the way back to Indian mystics. It works with chronic pain, depression, anxiety, coronary artery disease. John Kabat-Zinn at Boston Hospital uses MBSR training with all of their heart patients. Our biological system functions as a whole, right? Long time ago, it was the body and the brain. There is no separation, and I'm preaching to the choir here because you all know that this thing is connected to your shoulders and it's connected to our body. It's all one. The arrangement permits the mind to influence the body. And when I talk to chronic pain patients, I say that this thing right here is the most powerful thing on the face of this earth. And we can do anything we want with chronic pain if we change the way we think about it. I believe that about 70%, it's a pretty high number, about 70% of a person's physical pain is an emotional response to their physical pain. And if we can overcome all of those emotions, we have at least a 70% reduction in pain. And I've seen it for 26 years. And it just works. When we take the emotion out of physical pain and physical disease, chronic disease, we see increased health and better living and healthier living. So in a mindful response with pain and distress is when someone has a pain flare-up, not to fight it. When we fight something, we think about it more, right? But if you allow it and accept whatever arises and you're non-judgmental about that pain flare-up, I know it's hard. And when you're first talking to people, it's really difficult to get that you can be non-judgmental about it. And if you let it be, you're going to have less pain. And again, about 4 weeks into the program or 3 weeks into the program, when they've been practicing this every single day, it is amazing to see their lives unfold and bloom into these new, amazing people. Can you go back to that slide real quick? The negative response, of course, is avoiding it and fighting it, right? And suppressing that depression, having anger about it, and ruminating on your pain and feeling really bad about it. So what we want to do is we really want to have a mindful response instead of a non-mindful reaction to our pain. And again, you can go, I think that was it, right? So I really believe that in working with chronic pain patients, it has to be multidisciplinary. One of the things that I hear all the time is patients will say, why is this going to work? I've tried yoga. Why? I've gone to my doctor. Why is this going to work? I've gone to Tai Chi. I've gone to massage, and it doesn't work. When you do it all under one roof, the other thing that happens is when someone goes to yoga and someone goes to an orthopedic surgeon or a pain doctor, and they go to two physicians, those two people rarely talk to each other. They don't have time to talk to each other. And they're not going to automatically fax the records. They're going to have to be requested, right? And so there's no continuity of care. You'll do all these modalities in all these different parts of London or wherever you live and all over Houston, but when it's done under one roof with a group of experts that understand your physical pain, there's just a huge life-changing experience. And so if you heard anything, it's that emotional response to pain that is so important. And if we can overcome the emotions related to pain, we can do anything in life that we want. So that's all. We're a little bit early. Thank you so much for coming. You're welcome to leave, but we're a little bit early. Does anybody have any questions, thoughts, concerns? Yes, ma'am.
So, if somebody's very resistant, so I have a relative who had 5 back operations, chronic pain for over 10 years, a lot of stress in her life, a lot of anxiety, a huge amount of painkillers, all of what you said, but is completely resistant to anything like mindfulness or looking at anything in the mind. She'll have another surgery or another implant or another anything.
Yep.
Does it still work?
So, very interesting question, and an extremely important and appropriate question. I would say, if I had to pick a number out of the air, that about 9 out of 10 patients are very resistant and don't want to do this because it's so much easier to go to a doctor and get a pill, and it's so much easier to complain, and it's so much easier, unfortunately, to feel bad than it is to feel good because it's an effort. Our residents, by the way, start at 7 o'clock in the morning, and they work until 7 o'clock in the evening. They're either in class or exercising 12 hours a day. And that starts on day 1. And every one of them say, there is no way. And I have a 17-year-old. In the state of Texas, we can treat a 17-year-old if the clinical director approves and they're able to mix in the milieu of an adult population. Right now, I have a chronic pain patient who's 17, and I have an 84-year-old. And that 84-year-old is really teaching this 17-year-old a lot of stuff right now. But when she came in, horrific, angry, mean, bitter at her family and me. So when families have a problem getting someone in, one of the things that I do is I think it's a skill that I have. I'm able to talk to people. I'm able to get on the phone with a loved one and really talk about. I'll give you another secret of the secret recipe of getting someone into treatment. When you talk to them and you say, I bet you've been really depressed lately. And I bet your pain has caused a lot of anger and grief and frustration. They think you're a magician. It's like, how did you know that? Because everyone is so mean to me and I'm angry. And so a lot of times I can build a rapport on a phone call with patients like that. And I can talk to a lot of people. When that doesn't work, I call Judith Landau and say, I need an interventionist to come help me get people in. But a lot of people don't want to go to treatment, and a lot of people don't want to go to a pain program and go through the effort because they really don't believe it's going to work. We have 18 beds in our program, for example, and we stay at a capacity of about 14 to 18, and we kind of fluctuate between 14 and 18. And the Mayo Clinic has 50 beds, and there's a 6-month waiting list to get in the Mayo Clinic. Betty Ford, I built the program at Betty Ford. They have 25 beds, and they maintain a very high occupancy. I built the pain program at Sierra Tucson, which is an amazing pain program as well, and they maintain a very high occupancy. So pain programs are doing well, and they're important, and we need them, but a lot of people just don't want to go. But it is talking to them and getting them to commit. And a lot of times I'll say, give it a week, and if you don't feel better in 7 days, then I'll tell your family you need to go home. And rarely does that happen.
By the way, I concur with and endorse everything you said.
Thank you.
And just one clinical comment. I had one patient who was an addicted nurse. She was injecting Demerol for many years until she got caught when patients went without their Demerol. But she complained of chronic pain, and after she'd been in recovery for her addiction for about sort of 5 or 6 months and having gone to many pain specialists, she showed up in my office, and I just happened, because I never talked about her back pain, because I knew it was not necessary. I said, how's your back pain? And her, no joke, her comment was, what pain? Yeah. She had forgotten.
Absolutely.
But despite that, do you find that it sounds that many of these patients have good recovery capital, and they've got lots of resources, psychological resources, which they're able to access with your help. But do you find that there are still some patients who are still being prescribed pregabalin or amitriptyline?
Mm-hmm. You know, here's my answer to that, another fantastic question. So in my program, 100% of the patients who successfully complete my program, meaning they complete 30 days, at a minimum 30 days, leave on an abstinence-based level, 0 medication. I will not do it in my program. And another thing is that my staff is highly skilled at is talking to them and educating them as to why it's not okay. There are other programs around the country that quite frankly, I started and built that were abstinence-based, and because of, I hate to say this, but because of marketing and ease of access, they're now saying you can leave on some type of medication. I'm not a believer in long-term Suboxone. I'm not a believer in long-term methadone for chronic pain at all. I've seen it work for 26 years, and you just don't need that type of medication for chronic pain. So what we'll do is we'll do an intervention while they're in treatment with the family and the patient if they're demanding medication and pain medication, and we're very successful at breaking that cycle. Yes, ma'am?
This is rather a spontaneous sort of question. It was hanging around a bit earlier for me. Just the thought about the attachment to the pain, you know, the identification of the person to the pain, because I agree with everything you've said here, and it's so refreshing. Yeah. But I wonder about that sort of personal identification. The pain is me, and if I don't have the pain, who am I? And I'm sure you address that as well.
Absolutely.
That and also just creativity, the artistic side. I'm sure you do that too.
Yes.
And I heard about the music.
One thing that wasn't up here, though, too, is an art therapist. It is amazing to see the art that a chronic pain patient will draw when they come in, and another a piece of art when they leave. It changes dramatically, and you get to talk about that over time, and the music is so important. And it is so many people's identity. They don't know who they are without their pain, and our psychological team is amazing at working and untwisting and tweezing through all of that. Anybody else? I know you have a question.
You answered mine.
Okay, yeah.
I was also wondering about that we get a lot of referrals for individuals that have been on Suboxone, methadone for very long periods of time. Mm-hmm. And I was just wondering what the detox process is, and how do you do that beforehand and get involved, or?
Absolutely.
Yeah.
So so many people are petrified and will call you and call a wonderful treatment program and say, I am not coming off of my Suboxone. My doctor prescribed it. It's less lethal than opiates. It's a good alternative. I'm not going to do it. And Paul Manley, who's my admissions director, and I do most of those phone calls with families and with loved ones. And I'm able to walk them through somewhat in an animated way, kind of a visual perception way of teaching them about Suboxone and what it does to our body long term, and asking them to give it an opportunity and saying, wouldn't you like to at least try it without it? And believe it or not, eight times out of 10, they'll say, I'll give it a try. And they leave our program without it. So we start detoxing from day one. And on Suboxone, if they've been taking it for a long time and they're on 64 milligrams, it's going to be a 15-day detox, right? I don't want to take someone off and have someone go into a seizure. So it's going to be longer term. And with methadone, it's going to be a longer term. But by the time they leave, they are off of it and well educated. Yeah. Yes, sir.
Thank you. Considering the phenomenology of the paradigm shift that you take them through in 4 weeks, do you find that 12-step meetings are enough for an architecture of support long term, including everything that you've gotten them between nutrition and mindfulness?
Right.
Or do you find that their long-term recovery needs more than just their local 12-step fellowship?
Yeah, I think it needs more. Again, we're very core 12-step, but we're also very core 12-step Chronic Pain Anonymous. And we're actually starting one in Los Angeles in the very near future. We've already organized the group. I have a lot of alum that have come out of Driftwood that are in LA now in that area, and San Francisco, who are starting CPA groups. But I believe that the 12-step core is a great program to follow, but I think they need some additional support. So the other thing that I do is I work, having done it for 26 years, I have support in LA or San Francisco or Boston that are psychologists or counselors who know how to work with our patients when they leave, and I'll refer to those folks because I think they need maintenance. And our alumni program is so strong. It's so important to stay connected, whether you're a chronic pain patient or an alcoholic. It's important to stay connected. And I think that, so they do, I think that just the AA program is incredible. But I think the chronic pain patients need a little more. Question? Anybody? Yeah? Yes.
So I'm thinking about a young man, 24, and he has a knee injury from when he was about 14. And it sort of comes and goes. And what you were saying about the pain being, the emotional reaction to that physical pain makes a lot of sense, because I think that sometimes when he's more stressed, when he's more angry, it's worse. And at other times he seems to be able to do a lot with it.
Yeah.
But he's also talked about the tension in the body. He's, it's very interesting. And then there's the mental health issues there too.
So that reminds me of several patients that I've seen over the years that are young men who were athletes in high school, or maybe even athlete as a freshman in high school who injured themselves and weren't able to play football or baseball or whatever it was, that years later into high school and college, they say that they have a pain complaint and they can't play, right? And they have knee problems and they have back problems, and it turns into this long-term chronic pain issue. But when you work with this and you work through that chronic pain issue with them, it goes away.
Sometimes it's there, sometimes it's not.
Right. It's stress-related, stress and emotions, absolutely. Grief, right? Lots of grief. Yeah, yes, sir.
I'm a doctor who specializes in addictions, but I also happen to be a GP, and I look after a couple of prisons in the UK. So you get loads of patients with chronic pain symptoms. We have these challenging conversations. They all want their pregabalins and gabapentins. They all want to be zonked out.
Yes.
They want the quetiapines, mirtazapine, anything that will send them sideways, upwards, or downwards. They need it.
Yes, of course.
And there's a long discussion. It starts with the tonsillitis, but then eventually ends up always in chronic pain.
Yes.
And usual story is that I started with the chronic pain 2 years ago. So with my knee pain, I sustained this injury 5 years ago. So and then it sort of builds up from there. So my question to you is, I mean, are you seeing a lot of that in the US as well? I mean, are you seeing an over-reliance on these? I mean, we went through a patch where we were prescribing a lot of these drugs.
Sure.
And then now I think GPs are becoming more and more aware of this, and we're prescribing less and less of it.
That's right.
The message hasn't particularly completely down the block, but we still see a few startups on pregabalins and gabapentins. But do you think that the love affair is over, even in America?
I think the love affair is ending quickly, but GPs in the United States are the #1 prescribers of opiates in our country. And absolutely no offense by saying this, and GPs in the United States have 3 hours of their entire medical school was pain, right? One, yeah, exactly. And that's not sufficient. So I think it's a lack of education in early on, but I think it's also a lack of education, and they're the frontline people. So the easiest thing to say is, here's gabapentin, it won't kill you, you can't overdose on it, take it, right? And then they become addicted to it when they say it's non-addictive, right? And they said you can't become addicted to OxyContin in the early 1990s, right? Purdue Pharma said this is a non-addictive opiate on OxyContin. You're in a difficult situation. I know you are. Any of these skills and techniques, and if you'll email me, I can email you, any of you, if you'll email me, I can email you tons of techniques that we use that are really simple techniques to talk to people about, or hand them something and say, read this and we'll talk about it next time, or try this, but I'm not writing a prescription for such and such for it. Let me get, yep, I'll come right back. Oh yeah, who? You?
What do you think of the program that was started in Denver, where they have a number of the hospitals in the emergency room where people are coming in, they want the opiates, and then instead they are getting counseling and all of this. Did you follow that at all?
That's my dream. I have not been made aware of that, but that's exactly, I'll give you a quick example. About 6 weeks ago, I was in Houston at a very busy emergency room. They asked me to come speak to their ER docs. So I went in at 5:30 in the morning because it was going to be shift change and the docs were leaving and going home. It was about 5:30 in the morning. I brought donuts and breakfast and stuff for them to eat. And there was 12 or 13 ER docs who sat in this room and listened to me. And this ER doc raised his hand and he said, I don't have time for this bullshit. He goes, I hear you. I believe it. I just treated 110 people last night. Do you really think I have time to do any of that you're talking about? I'm going to prescribe 10 hydrocodone and get them the heck out of here. Or 10 Vicodin and get them out of here because I don't have time for it. So if you can do community-based counseling and say in a triage, we're going to sit you with our counselor, we're going to sit you with our psychologist, our mental health department first, right?
I'm not sure of all the details as to who they might have brought in addition, but my understanding was it was with the regular staff that they had expected something like perhaps a 5% reduction, and they have gotten some phenomenal results just by spending a little bit of time counseling the person, and they'll walk out with the Tylenol.
That's huge.
You know, so
thank you. I want to look into that with you. Yeah.
It's kind of the same question. I'm pretty loud. I don't need microphone.
Yeah.
It's just being recorded. Oh, okay. Okay, fine.
You're on camera.
Yes. So thank you for I love your presentations always, and a big fan of mindful approaches to pain, and how I guess I'm piggybacking on all of this last two questions. Kind of like as a society to promote education, to promote public awareness of this whole thing. And I have an example. I had natural childbirth by Bradley method, which I was preparing for, and it was amazing. My pain was at 2 during the labor. So, and I had like nurses and doctors running after me offering all types of things and epidural and all of that. And I actually actively was fighting through the whole process.
Sure.
And again, they're like, you can't do it without it. So how do we promote education? I don't know. I mean, it is a crisis. And
It is.
I'm on the board of a nonprofit. I went to Washington, D.C. I met with Congress people. But it's like, they're like, we don't have time for that.
Right.
So, like, what do we do as professionals, as the industry, what can we do?
You know, wonderful question, because it all boils down to education. Education, education, education. And it starts with physicians. It starts with the guys who went to medical school to treat people and heal people. And you may want to address this. But again, they have the best intentions, and they're inundated with people who want instant gratification of a prescription, right? And they will do anything. I've had patients with 27 back surgeries who didn't need it the first time, right? And once you cut, there's scar tissue, and it continues to build, and it continues to build, and pain is going to continue to get worse, and lives are just going to spiral down. So, you know, I think I'm learning more about the UK, but in the United States, it's almost being forced at this point because we're cutting back. There are physicians in the US going to prison now, and whose practices are being raided by the Drug Enforcement Agency and the FBI, and they're walking in and literally taking their computers out of their office and looking at their prescribing patterns and arresting physicians and putting them in prison. Not a lot. That's pretty excessive, but it is happening. I'm not saying I'm an advocate of it, because I'd rather educate the doctors, but it's also our responsibility, right? And our own practices, when we all work with people who have twinges and a little bit of pain, just to teach them these little small exercises and saying and educating people, the answer is not an opiate. The answer is not Vicodin. The answer isn't a pill. Just like it's not a beer or a bottle of vodka, it's not a bottle of OxyContin or hydrocodone. So I think it's education.
Physicians are enablers.
Yes.
They like to please people.
Yes.
But for 30 years, I've tried to introduce better teaching about pain management at the local university.
Yeah.
And met with unbelievable resistance.
Yeah. You know why, don't you?
Physicians are reactionary, conservative. They don't like change.
And it's threatening. And one big thing is it's really threatening to the hospital's paycheck. Yeah. It just is. Psychology and mental health and yoga and Tai Chi and all of this really hurts the bottom line of a healthcare organization. And that's a really unfortunate scale imbalance. Yes, you bet.
Yeah, just one more thing to add, because we're talking about enabling the patients, giving people a tool which they can take away. And I started learning TRE for myself, trauma release exercises.
With who?
I'm
you know
now
Steve Haynes?
No, I'm now learning it with TRE UK, rebranded, slightly different people, Total Release Experience.
Yes.
I've used it for myself. It's amazing, and I feel younger. My body's, it's much more flexible. And now I've had my first 2 case studies, and they haven't got the chronic pain. The woman hasn't had to use her asthma medication, and she hasn't needed any migraines since as well. So you have it, I'm sure.
No, but yesterday I did my very first session of TRE education by a gentleman here in London, and everybody should write this down that lives here or not. His name is Steve Haynes, Haines, and he published a book, and it says, the name of the book is Pain is Really Strange. And simple book, Pain is Really Strange. It takes about 30 minutes to read. As a physician, you would be amazed at this book. I have been practicing for 26 years. I come out of academia, some of the best institutions in the country, and this is the best book I've ever had. And it's pardon me?
What's the name of the
Steve Haynes. Yeah, Steve Haynes, and it's Pain is Really Strange. It's on Amazon for like $7, and he lives right here in London, and I emailed him before coming over here. I give it to every patient I have, and I make them read it. I tell them, I need you to read this 3 times, and it takes you 30 minutes each time, and then we're going to sit down and talk about it, and it changes their lives. And some of it is about TRE.
Yeah. Marvelous, yeah. And there's also treuk.com.
Got it. I'll look at that.
They're brilliant.
Thank you.
Thank you.
Yeah. So if you guys would do me a favor and tell Sam that I was okay at this, and she might want to invite me back, it will help me out. Thank you. Yeah. Thanks.